This lecture will provide an overview of Chapter 3 of the text. The U.S. healthcare system is like none other in the world, so it's important to understand how this system evolved to the system we have today. First, we will examine the role government played in the evolution of the healthcare system and who the stakeholders were in this process. Next, we will consider the role health policy plays in the healthcare system. The Constitution does not empower the federal government with the responsibility for health or health care. This responsibility was left to the states. It is only through the power of taxation to provide for the general welfare and the power to regulate interstate commerce that the federal government has evolved as a payer and a regulator. Local governments and states initially took responsibility to provide for the welfare of the elderly, poor, and disabled. The role of private medicine developed as a relationship between the patient and the provider, and that role was held sacred. The individual physician had complete control over his medical practice. This autonomous role of the physician largely shaped how government programs and insurance evolved. As the practice of medicine became based on science, the practice of medicine moved from the homes of patients to the hospital. As medical care became more advanced and required more services, the cost of health care began to rise. In the late 1920s, hospital costs had grown beyond the ability of many Americans to pay. In 1929, a group of Dallas area teachers offered to prepay premiums to Baylor Hospital in exchange for up to 21 days of future care. The implementation of this plan, known as the Baylor Plan, was the forerunner of the insurance company Blue Cross. This plan sparked many different types of employer plans to cover hospital care. Following World War II, the federal government provided a significant incentive for the purchase of private health insurance by making insurance premiums provided through employment tax exempt. This benefit allowed workers to essentially get wage increases in the form of health insurance benefits that were not taxable. The federal government also supported hospital construction during this time by passing the Hill-Burton Act, which gave hospitals grants and loans for construction if they agreed to provide services to persons who were unable to pay. By the mid-1950s, employer-sponsored health insurance was the primary means for Americans to afford the rising costs of health care. Although employer-sponsored health insurance covered the worker, many times the family was not covered, and also there were many who did not have health insurance and did not have the money to pay for health care. This included people who were retired, elderly, disabled, unemployed, self-employed, part-time workers, or those who worked for businesses that did not provide health insurance. President Harry Truman in the 1940s proposed a system of universal government insurance to replace private employer insurance in the late 1940s. This proposal was met with stiff opposition from physicians, insurance companies, and businesses. In the 1950s, an amendment was passed to the Social Security Act to provide federal funds to states willing to pay healthcare providers to care for welfare recipients. In 1965, as part of President Lyndon Johnson's Great Society Initiative, Congress passed amendments to the Social Security Act to provide hospital insurance for the aged, Medicare Part A, physician insurance for the aged, and Medicare Part B and health insurance for the poor, Medicaid. The Medicaid program is provided through a state and federal partnership. States must follow federal guidelines but have flexibility in how the program is administered. Funding is a combination of state and federal funds based on the percentage of persons in the state who could qualify for the program. As of February 2018, there are 74 million Medicaid recipients who are low-income children, adults, seniors, and people with disabilities. In 2016, the cost of Medicaid was $53.5 billion federal and state dollars. The ACA originally mandated all states to expand Medicaid to people with annual incomes below 138% of the federal poverty level. This mandate was challenged by states, and ultimately the Supreme Court struck down the mandated expansion. 32 states, including Washington, D.C., have expanded Medicaid through the Affordable Care Act. This expansion has been responsible for increased costs of Medicaid, with the expansion largely including low-income adults between the ages of 18 and 64. In 1965, nearly half of all seniors lacked medical insurance. Medicare was created along with Medicaid in 1965 as an amendment to the Social Security Act. The program was initially established to provide health insurance to individuals aged 65 and older, regardless of income or medical history. In 1972, the program was expanded to include individuals under the age of 65 with permanent disabilities receiving Social Security disability insurance payments, and also people suffering from end-stage renal disease. In 2001, individuals with ALS or Lou Gehrig's disease also became eligible. Unlike Medicaid, which is administered by states, Medicare is administered and funded by the federal government. Medicare has a limited benefits package and also has substantial copays and deductibles. There are 4 parts to Medicare. Part A, also known as the Hospital Insurance Program, covers inpatient hospital services, limited skilled nursing facility services, home health, and hospice. Part A is funded by a tax of 2.9% on earnings paid by employers and workers, 1.45% each. The Affordable Care Act increased the Medicare Part A payroll tax for high-income taxpayers. Part A benefits are subject to a deductible and coinsurance. Part B Medicare is voluntary, but more than 90% of beneficiaries with Part A are also enrolled in Part B. Medicare Part B is supplemental insurance that helps pay for physician, outpatient, home health, and preventive services. Part B is funded by federal general revenues and beneficiary premiums. Beneficiaries with higher incomes pay a higher premium. Part B benefits are subject to a deductible and cost sharing. Part C, or Medicare Advantage, allows beneficiaries to enroll in private insurance plans who provide Medicare services, primarily health maintenance or preferred provider organizations, and receive all Medicare covered Part A and Part B benefits, and usually Part D benefits. Part D is the outpatient prescription drug benefit established by the Medicare Modernization Act of 2003 that was implemented in 2006. Individuals who sign up for Part D generally pay a monthly premium, but may receive assistance if they are low income. During the 2000s, the number of Americans without health insurance grew from 40 million to 46 million. Many people who had insurance were either underinsured with high out-of-pocket expense like copays and deductibles. The increase in the uninsured largely coincided with reductions in employer-sponsored insurance. With rising insurance premiums, employers either increased the amount employees had to pay or quit covering family members. Small employers could not afford to provide health insurance to their employees. During the 1990s, various employer mandates were proposed, with the argument that the expense would cause employers to eliminate jobs. In the 1990s, the focus of insurance coverage shifted to the vulnerable population of children. Children's insurance gained bipartisan support, and Congress enacted the State Children's Health Insurance Program, named CHIP, in 1997. States can use CHIP funds to expand Medicaid for children or develop a separate state program. CHIP did little to reduce the number of uninsured, and the 2008 presidential campaign focused on health reform. In 2010, the Affordable Care Act was enacted with a goal to reduce the number of uninsured, provide health care coverage without increasing the deficit, put measures in place to slow the rising cost of health care, and enact policies that encourage a more efficient delivery system. Key components of the act was to mandate health insurance or pay a penalty, to expand Medicaid, to create an insurance exchange where small businesses and the uninsured could purchase insurance with a federal subsidy, mandate employers with more than 50 employees to provide health insurance, and require insurance companies to comply with federal regulations that sought to eliminate discrimination for pre-existing conditions. One of the objectives of this course is to understand the dynamics of the policy process and analyze policy decisions. The text describes 4 key characteristics of the policy process. The first is that each health program or problem related to health and healthcare has a distinct policy subsystem. The policy subsystem is really the group of policy stakeholders who have a vested interest in the policy problem and are interested in shaping that policy to achieve specific goals. As part of this course, you will be analyzing specific healthcare problems and identifying the subsystem or stakeholders. The second characteristic of the American system is fragmentation. Some would say we do not have a healthcare system, as we have many pieces of a healthcare system that are fragmented. They do not work together. And our system of government is very difficult to enact major policy changes in the healthcare system. There are so many stakeholders with often conflicting objectives. In our system, change is often made incrementally, as it is easier to make incremental change. The third characteristic described is that of implementation of policy and how critical it is to the policy process. Once a bill becomes law, there are many federal agencies that develop the rules about how these laws are interpreted and implemented. The fourth characteristic is how the establishment of health programs like Medicare and Medicaid impact the policy subsystem or the stakeholders. Once that program is enacted, it's pretty hard to get rid of it if it is popular. And also, programs sometimes just die due to barriers or lack of support. An example of this policy process is the Medicaid program. When Medicaid was enacted in 1965, it was very different from the Medicaid program we have today. Medicaid is a voluntary program for states. Initially, quite a few states did not participate in Medicaid, while others saw Medicaid as an opportunity to extend health insurance to a large proportion of their population. This resulted in an increase in cost. One of the initial changes to Medicaid was to limit eligibility in order to limit cost. Despite limits on eligibility, Medicaid continued to grow, especially in the area of providing long-term institutional care for the elderly and people with disabilities. The period of the 80s and 90s saw additional growth in Medicaid. One program was Medicaid's disproportionate share hospital program. This program provided funds to hospitals who served a high number of uninsured and Medicaid enrollees. An additional expansion during this time was the expansion to cover children younger than 6 years of age and pregnant women with incomes up to 133% of poverty. Other programs through the 90s and early 2000s included welfare reform and the Children's Health Insurance Program. During this period, Medicaid waivers allowed states to experiment with new approaches to Medicaid, including managed care and expanding Medicaid to new populations. The period of health reform that followed in 2009 gave rise to Medicaid expansion as a key component of the Affordable Care Act. A number of factors described in your text supported the growth of the Medicaid program. The saga continues with a Republican-dominated Congress who not only blocked Medicaid expansion, but also have tried to convert Medicaid to a block grant in order to decrease the growth and cost of the program. The factors that contribute to potential reduction of the Medicaid program are typical of any policy process. The party in power, the support or lack of support of the public all play a role. The Medicaid program is a good example of the forces that push for expansion and then push for contraction of the program. This semester, we will continue to consider health policy and how it affects virtually every aspect of the U.S. healthcare system.